All right, we are at a large number of participants, so let's start tonight. Welcome, everybody. Thank you for joining us tonight. Welcome to our webinar. I'm Wendy Golden. I'm an endodontist and medical affairs at Sohn Endo. Let's review a little bit about tonight's webinar. Tonight, we are going to compare and contrast what are the different mechanisms of action. What are their advantages and disadvantages in various root canal irrigation techniques? We're going to talk about positive pressure, different lasers, dynamic cavitation, and multisonication. We're going to look at some current histological and microbiological evidence regarding the efficacy of these techniques in removing and disinfecting the root canal and preserving the root canal structure. And lastly, look at some clinical implications of these technologies, looking at their benefits, their drawbacks, and appropriate indications in different clinical scenarios. The webinar does include one CE. Let's review the CE process. One, you must be registered for tonight's Zoom. Your attendance will be recorded. After that, we are going to send you a survey to your email. We ask that you complete the survey, and then the CE certificate will be sent to you via email. If you have any questions along the way, please reach out to myself or education@sonendo.com. So tonight we would like an interactive session, and your questions are deeply encouraged. There is going to be a dedicated Q&A at the end of David's presentation. During that time, if questions arise, please place them in the chat box. And we're going to try to allow for a good 20 to 30 minutes of Q&A where you're welcome to come off mute and camera, hopefully, and ask questions to him directly. So it is my pleasure to introduce you to Dr. David Jaramillo. Dr. Jaramillo has published over 30 peer-reviewed papers. He's written 8 book chapters, both in Spanish and Portuguese. He is a full professor of endodontics at the University of Texas Health Science at Houston. So I'm going to turn it over to you.
Thank you so much, Wendy. Welcome, everybody. Thank you for being here. We are going to talk about different lab. Now that I presented this topic at the AAE, when I was reviewing the reviews of my presentation, there was one comment saying, this guy only talk about what he does. And exactly that it's what about it. I obviously do a reference to literature, but what I'm going to show you tonight is what I do in the lab, because I want to test what's out there. And I hope I can bring you and clarify for you some doubts that you might have. Let me start with my presentation. I think that I'm going to need to go back to the first slide. And now I'm going to start. So tonight talk is Tissue Talks. The latest research uncovers what's really happening inside the root canal. I'm a professor, a tenured professor of endodontics, as Wendy said, here at the University of Texas Health Science Center at Houston. I've been teaching for the last 35 years in USC, in Southern California, Los Angeles, then Malinda University, and since 2014 here in Houston. So I need to disclose that I have research related financial interests with Sohn Endo. I do some talks for them. I receive honorariums for doing that. Part of the research that I'm going to present tonight was done with a grant from Sohn Endo. But something important is that I don't have direct access to the money. The money goes from Sohn Endo account into the university account, and the university is in charge of handling the money. I don't get any money out of it. And also some projects has been funded by the American Association of Endodontics. So I would like to start with this one because this is funny. Dentists must recognize that complete pulp removal in most teeth is an unrealistic expectation, given the complex network of foramina and dentinal ramification. This was said by Davis Clyde back in 1922, over 103 years ago. So basically, we are in the same spot. Uh, the complexity of the root canal system is such that we haven't been able to find a way how to properly debride the pulp tissue from all those inaccessible areas, all those difficult to reach areas like isthmuses, lateral canals, fins, etc. Historically, prominent people like the Judy Cutler and Corey Langeland, they emphasize that the instrumentation is the primary focus of the root canal treatment. But at the same time, Dr. Schilder, which we all know very well, these three people, um, they Dr. Schilder claimed the cleaning and shaping of the root canal system. So he was talking about the system itself, but Dr. Cutler, Jody Cutler, and Corey Langeland, they were more focused into what we really can do. And what we really can do is to treat the main root canal. We cannot go and treat those lateral canals or the isthmuses because we cannot do that on the conventional way of doing root canal treatment. So we need to understand that the practice of endodontics, how much it has evolved into the contemporary dentistry. So our field of action is the main root canal. That's where our work needs to be dedicated or is dedicated. But with these irrigation techniques, we try to implement and improve the debridement of the pulp tissue from those difficult to reach areas. Have we been successful trying to do that? Well, we have in some aspect, but we haven't completely. So again, I'm going to talk to you about what I have done and what are my findings. So through the years, I have been searching and doing research on the disinfection of the root canal. Uh, some some papers are criticized because of the methodology, but unfortunately, we don't have better methodology in endodontics, like infecting straight root canals and then disinfecting those straight root canals. Well, that doesn't make a real difference. So the disinfection is try to compare different solutions, different instrumentation, different irrigation technique, and see which way could be the best way to disinfect the root canal. So evaluation of the efficacy of root canal disinfection comparing three different techniques: ultrasonic, sonication, and positive pressure. As we all know, positive pressure is the most common used technique that we normally perform in the office. Some people uses the sonication, and some other uses the ultrasonication. So what we did, we have the three groups, and we infect those single-rooted teeth with Ificalis for 4 weeks. We supplement the broth with glucose, and we replace the broth every other day in order to keep a healthy broth with great nutrients for the bacteria to keep developing, right? So we want to be sure that those root canals are well infected. So we standardize the size of the root canal, we standardize the amount of solution we do, and we standardize how we do each one of the protocols. So at the end, the statistical analysis shows that there is not a big difference in between the three techniques. In order to be able to get statistical difference, well, we need to do too many cases, too many samples, like 150, 180 samples per group. So that's basically unrealistic to do in vitro. So we need to keep in mind this, that mostly of all these studies are done in this model, which might not be the ideal model, but this is what we have. Several years ago, Dr. What is his name? I forget his name right now, but he came up with the concept of the negative pressure, uh, and he launched what is known as the endovac. Endovac is uh, a device that uses suction, and we use two different type of cannulas. One is the macro cannula, and the other one is the micro cannula. This micro cannula is equivalent to a size number 3500, and at the tip of the cannula, it has micro holes that are responsible to suck out the irrigant from the inside the root canal. So the device has a master tip where we deliver solution in the pulp chamber area, and the micro cannula is placed all the way to working length, and this micro cannula is going to be responsible for sucking out the sodium hypochlorite that is being delivered into the pulp chamber and inside the root canals. This is a good way to deliver sodium hypochlorite all the way to working length and break. This is one of the technologies that can break the famous vapor lock, because the vapor lock is not going to be um, removed by a file or a hand file or rotary file or a the gutta percha dynamic technique. Nothing of that, or the simple needle irrigation. That's not going to break the vapor lock. The vapor lock is going to be broken only by the endovac or other techniques like laser activation or multisonication. So we tested a new modified endovac done by Brasseler. It's called TotalVac. This is not a commercial. This is what we did in the lab with Julian Shen, one of our former residents. This was her master's thesis. So the endovac, as I was mentioning to you, has a macro cannula and a micro cannula with these micro orifices here. And this is the master delivery tip. The problem with this technique is that we need 4 hands to use it. We need an assistant to be there with us, and we need 4 hands to use it. So Brasseler come up with this TotalVac, which can be used with 1 hand, according to them, but it's not. You need 4 hands also. So it's a more simplified device, again with a similar delivery tip, as you can see here, delivery tip, the macro cannula, and instead of micro cannula, they use the ASA number 30 irrigation needle with a side vented hole. So it's basically the same concept. So we also wanted to try the Slayman sequence. The Slayman sequence we published several years ago, that with Slayman sequence, which it implements the use of more volume of solution. It's 24 milliliters per root canal, but that's a lot. That's too much. So we combine and we altern the use of sodium hypochlorite water, EDTA, sodium hypochlorite water, EDTA, in order to prevent the mixture of the solutions inside the root canal. But basically, this mixing of solution is more like an urban legend, because a total of 30 microliters probably is what can fit in the root canal. So the amount of solution that got in contact inside the root canal and the time where they are in contact is so short that basically, if they mix together, any chemical reaction that could happen is not gonna be against our root canal treatment. So I'm not too concerned about that. So um, we did these groups: the conventional endovac, the Slayman sequence, the ultrasonic activation with the e-receive tip, and total back. This we have two papers. The second one here, the one from Wong, we test this sequence to see the removal of a smear layer from the canal wall, and basically doing this sequence is better than using an alternating sodium hypochlorite and EDTA in less amount of milliliters. And then my son published his paper on the use of the same sequence, and he found that bacteriologically speaking, it was more effective than the conventional irrigation technique. So here are our numbers. S1 is the initial population of bacteria inside the root canal, and S2 is the amount of colony-forming units recover after the irrigation protocol. So as you can see here, there is not a big difference in between ultrasonic and the total back or the conventional endovac or the Slayman sequence, where we found less amount of bacteria. But again, due to the amount of samples, we couldn't find statistical difference. But there was a difference in between. The more solution we use, the better. So this is another study that we did with another one of our residents, where we compared the water laser unit, which is a erbium chromium YLGG laser. We compared it to ultrasonic. Again, we contaminated the root canals with Ificalis for 4 weeks. We supplemented the brain heart infusion broth. We changed the broth every other day in order to keep a good environment for the bacteria to keep growing. This was the methodology. We decoronate the roots. We prep the root canals to the 3504. Then we contaminated the root canals and we performed the irrigation with the ultrasonic and water lace. We use 0.5% sodium hypochlorite. Why 0.5% sodium hypochlorite? First of all, 0.5% is totally backed by the literature, especially from the Scandinavian school, and actually some parts of the East Coast of the United States, they like to use lower concentration of sodium hypochlorite. Me personally, I like to use the Dakin solution, which is 0.5 sodium hypochlorite, but I buffer the solution in order to uh, turn the sodium hypochlorite from its iconic form into molecular form. That way, the chlorine ion will be more active and will be more effective disinfecting. Because if in vitro conditions we use a 6%, 8% sodium hypochlorite, we're gonna kill everything. The 0.5% still has a very good disinfection power, but it's not as aggressive as a 6% in vitro conditions. So that's why we use that. So basically, we have the bacteria growth to the 10 to the minus 7 uh, with good amount of bacterial growth when we grow it in the lab. And after the treatment, there was a good dilution of the solution of the disinfection of the root canal, and we didn't find any difference in between in between both groups. Something that caught my attention, Dr. DeVito, some of you might know him, but Dr. DeVito is the pioneer of the laser assisted irrigation, LAI. And back in the years when he started studying the use of laser for the root canal irrigation, he started using the erbium chromium YSGG laser. But he realized that he couldn't get the results he was looking for. So then he went to use the erbium jack laser, and we're going to talk a little bit more about the differences in between both. So the problem with this type of laser, erbium chromium YSGG, is a very good laser. There's nothing wrong with it, but the amount of absorption of the laser in the solution is not as effective as the erbium YSG erbium jack laser. There is a difference of 300% in the absorption of the laser in the solution, because when we use laser for the root canal irrigation, the laser per se is not performing the disinfection. The disinfection is being performed by the solution we use. And the way the solution is going to be enhanced to act and have a better dissolution of the tissue or better disinfection of the root canal is by the way this laser is being absorbed in the solution. So there's a big difference again. Erbium jack laser is being absorbed 300% more than erbium chromium YSGG laser. So in order to make it to help this laser to be absorbed better in the water, we need to keep a higher parameters, more watts, more millijoules, more microseconds, or less microseconds. But the problem by doing this, then it turns the event into a thermal event. So when we have excessive thermal event, we are going to produce more evaporization of the solution inside the root canal. And by that, we are going to create ablation. So in these pictures, what I'm trying to show you with these SEM images is the ablation created by the erbium chromium YSGG laser in the root canal wall. So some of the users, and we have it in the clinic, it's hard to take the tip all the way down because you cannot take it all the way down to the working length. You need to stay halfway, and sometimes the resident creates a ledge in the curve, so they need to keep instrumenting in order to reduce the ledge so they can place the gutta cone. And this is the biofilm created for this research. Then another research that we have done with ultrasonic is to compare two different type of ultrasonic units, the conventional ultrasonic unit versus the cordless ultrasonic unit and endovac. We didn't find any difference in between those. This is the XP finisher file. Probably some of you have used it. We compared to ultrasonic, and we wanted to see what is the efficacy in the disinfection of this device, of this file. This file is at 2500, but when it comes into reaches the body temperature, it changes the phase and it bends like this, so it increases its size to a number 90. So the reason to create this instrument was to have a more contact with the root canal walls, because as you know, and according to the literature, we have papers from this group in Barcelona, and the papers from Ove Peters from 2001 and 2003, where he shows, and we show with micro-CT, that in between 35% to 40% of the root canal wall remains untouched with any type of rotary instrument. It could be rotary, it could be reciprocation, it could be with a certain shape. It doesn't matter what type of rotary instrument we use. It could be blue, it could be gold, it could be purple, or whatever color you want. It's not going to touch 100% of the root canal surface. So with this instrument, what they intended to do is to have a more contact with the canal wall so you can scrape better and reduce better the pulp tissue or the bacteria located inside the root canal. So we use water because we wanted to see the mechanical aspect. Well, not water, but buffers, phosphate buffer solution. Um, and here we see the graphs of S1. S1, let's remember that is the initial count of the colony-forming units from the infected root canal, and S2 is the measurement of after we did the treatment. So we didn't find any differences between both techniques, but we did find difference in between the S1 and S2. There was a huge reduction of the bacterial population from the infected root canal. But in between ultrasonic and the XP, we didn't find any difference. Again, we don't have the right models, the right lab models. Something that really caught my attention with this project was that, well, I don't know how many SEM images I have taken through all these years, but let me explain to you what are we seeing here. This is an SEM image, 2500 uh, magnification. See this one in the middle portion of the root canal. Okay, these two pictures are from the coronal portion of the root canal. And something I never seen before was this amount of debris packed into the dentinal tubules. So probably the whipping effect of this file touching the root canal wall, probably it pushes the debris inside the dentinal tubules. I never seen anything like this in any other project. This is the apical portion. Let's remember that in the apical portion, there's a less amount of dentinal tubules, but still we can see some dentinal tubules plugged here in this area. And something that why I showing you this picture is that you need to be careful with the instrument because the instrument might break inside the root canal. So be careful with that. Okay, so this is a glass tube with bovine tissue here, and this is ultrasonic. This one is working here, as you can see, but we barely see some bubbles here floating around, right? But this is the effect of the ultrasonic, basically zero. We have a publication with Dr. Cox where we measure by velocimetry the displacement of microspheres, and we compare ultrasonic to pips. And what we did was to measure the velocity of the displacement and the distance of the displacement. So what we found was very interesting because let me stop this video because we found this tip is PIPS. This is erbium jack laser. The technique of PIPS is to leave this tip in the pulp chamber. We don't go inside the root canal, and look at the effect that it has. It's really being absorbed in the solution. Okay, the laser is really being absorbed in the solution. While this is water lace, 4 watts, and this is Edge Pro, 2 watts, and we can barely see activity here. So that's why I was telling you that there is a 300% difference in the absorption. Somebody posted a video on Facebook of a glass of water with having the laser tip of the water lace and producing a lot of bubbles. But the tip they use is a very big tip. It's not an endo tip like this one. So it doesn't make any sense. But the pips technique keep us in the pulp chamber. The efficacy of the technique will be on the absorption, how the laser is absorbed and how it produces this streaming. that we, in this study that I was telling you about with Dr. Koch and Dr. DeVito and Dr. Peters and myself, we found activity from the tip of the pips 18 millimeters away from the tip. There was displacement with a good amount of speed and distance. And in the ultrasonic group, we didn't find any displacement 2 millimeters from the tip of the ultrasonic probe. So basically, there's only activity around the ultrasonic tip. We just published this paper where we compare, where we did an SEM and bacteriological evidence of the laser activation irrigation. When we compare the water lace to the H Pro units, and again, these pictures are the ones I just show you. The problem with the laser is, again, the thermal effect that it produces. And these were done in lower molars, the mesial root of lower molars. It was very challenging because split a tooth is not easy, and splitting a mesial root where we can catch the canals, both canals, mesiobuccal and mesiolingual, and the isthmus is very challenging, but we were able to do it. And here we can see the amount of debris that is left. You can find this paper online, and we can see a lot of debris. This is biofilm that we contaminated the root canal with biofilm, with bacteria. This is in between the isthmus. This is a lateral canal full of pulp tissue. So the streaming produced by water lace inside the root canal system in the mesial root of lower molars, this streaming wasn't good enough to go into the dentin, into the isthmuses, debride the tissue, and debride the bacteria from those areas. And something we find very interesting was that when the laser tip is new, it has this tip here, like we can see here, and it produces this halo. Okay, and after use, we can see the degradation of the tip, as you can see here, only used for 1 minute, and the halo is gone. We measure the power of the laser before and after, and there is a big difference in between the power that is coming out at the tip of the laser because the degradation of the tip. So I don't know if you are a laser user. I don't know if you were aware of this, but this is something you really wanna know about this because these tips cannot be reused. Actually, I don't recommend you to reuse it. Uh, then with another one of our residents, Dr. Fang, we did this dissolution of bovine palatal tissue with the gas sodium hypochlorite, and we compare it to ultrasonic. We created this apparatus which has a micro mesh here. This is the bovine tissue, 70 milligrams of bovine tissue. And then we activated, we did it with 3% sodium hypochlorite and 0.5% sodium hypochlorite. So we will see here I don't know if there's a sound. It shouldn't be a sound, but we can see the efficacy as you can visualize in the video. Contrary to the other techniques that they produce streaming and a lot of bubbles, macro bubbles and micro bubbles, the degas solution doesn't have bubbles, and that's what is very unique about this GentleWave because the solution is going to be more totally in contact with any surface. While when we have an streaming, those bubbles might interfere with the rest of the solution to touch or to go into certain areas. So at the same time, when the bubbles are being produced and they cushion among them, that could be also not what we expected. So here, after a minute, more or less, we can see that basically the tissue is gone. So the way we did this study, after we ran the cycle, we removed the solution and we tried to save whatever was left there, and we pre-weight and post-weight the tissue. So basically, these are our results summarized in this table. When we use GentleWave with 0.5% of sodium hypochlorite, we got 100% dissolved dissolution of the tissue in an average time of 3 minutes, 45 seconds, I'm sorry. When we use GentleWave with 3% sodium hypochlorite, we found 100% dissolution after, in an average, 1.5 minutes. When we use only GentleWave only with water, we found 33% dissolution after 5 minutes, a full cycle of 5 minutes of water, while after full 5 minutes of ultrasonication, we only found 9% dissolution of the of the of the tissue. If you remember the model, we work basically with the same amount of solution. So that was the difference. Now, a lot of people has asked me about the ATP. ATP, as you know, is the source of energy that any cells needs or produces to function. It could be bacteria, it could be blood, it could be tissue, whatever cells. It produces the ATP. So Randy Cross has the idea to produce something that could be used in the chair side as one of our working tools. And so Dr. Bergenholz, back in 2015, he published his paper with was a rapid method for the detection of root canal bacteria in endodontic therapy. So here it says, by measuring ATP levels, a key indicator of cellular activity, the Endocators provides a rapid assessment of root canal cleanliness. A lower ATP reading generally correlates with a more effective clean canal, reducing the risk of post-treatment complications. The Endocator, is an innovative chairside disinfection test designed to evaluate the cleanliness of the root canal by detecting the presence of phosphorylated adenosine, ATP, ADP, or AMP, essential molecules found in all forms of life. The interaction in between ATP and the luciferase enzyme generates which the Endocator detects in just 10 seconds. So this is the way the Endocator works, by the generation of light. The machine detects it, and we can have a very fast reading. This is how it works. So in Bergenholz's study, he did his bacteriological studies here, results of the bacteria that he works with, and then he tried the ATP for the detection, and the results were very similar. The same here, the 100% formation of bacteria in the S1, and then after the treatment, they were able to correlate the remaining bacteria compared to the bacteria that has been um, 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 removed or deleted from the root canal. And this is with S3 is with calcium hydroxide after 1 week inside the root canal. So definitely the ATP is a good tool to evaluate the cleanliness of the root canal, but it not only detects bacteria. Again, if we have done the try, like for example, upper lower molar, I have clean shape MB, DB, and palatal without instrumenting MB2. I take my sample, and it gives me before it gives me a reading of 100. Then after I instrumented, it gives me a reading of 35, 40. And then when I instrument MB2, the reading goes down to 5, 4, 3, 6, whatever it is. So if there are remnants of pulp tissue still located inside the root canal, it's going to be detected by the endocator. So this is a good device that can tell us how well we have debrided the root canal or how well we have disinfected the root canal. So I ran a little study with this, a little pilot study with the endocator. Um, Obviously, there are limitations like indirect measurement. The endocator measure ATP, a bioproduct of similar metabolism rather than bacteria directly. As I was telling you, blood, tissue, etc. Sensitivity, the endocator may not be sensitive enough to detect very low levels of bacteria, so there can still be bacteria inside the root canal. Specificity, factors other than bacteria such as blood, tissue, debris, and certain irritants. When I was a resident back in the 80s, we used to take in pulm necrosis cases, we used to take a sample from the root canal at the beginning, then instrument. After instrumentation and irrigation, we used to take a second sample and then we place calcium hydroxide inside the root canal. We send the patient back home. 1 week later, the patient will come back. We will eliminate the calcium hydroxide, take a third sample, and obturate the root canal. If that third sample became positive, we needed to call the patient back to go to the clinic, remove gutta percha, instrument more, and place calcium hydroxide again, and do it again until we get a negative culture. It was time consuming sometimes, but it's a good way to learn uh, when you are instrumenting and disinfecting a root canal. We don't do that anymore, obviously, but that's the way we used to do it. So if we had this device back then, it would have saved us a lot of time. So what we did again, the same for uh, we supplemented the broth with glucose, and then we replaced the broth every other day to keep the best nutrients possible for the bacteria. So we use the ultrasonic irrigation with the irisate tip, the typical 3 cycles of 20 seconds. The other day, I was having a very interesting conversation with one of my colleagues, and he asked me why you guys in the lab keep doing what used to be called passive ultrasonic irrigation, which Dr. Botsukis uh, published in 2016 that the term is wrong. The term should be ultrasonic activated irrigation. And he used ultra speed movies to show how the ultrasonic probe contacts constantly the canal wall. So by having this contact, it cannot be passive. So he proposed to change the name of passive ultrasonic irrigation to ultrasonic activated irrigation. So I'm totally in favor of that. So my colleague was asking me, why you guys keep doing that? Why don't you do a constant, continuous irrigation while you are using the ultrasonic probe inside the root canal? And I say, you know what? Yes, the more irrigant you use, the better, but it is what it is in the literature. So that's why we keep doing that. So in group one, we use ultrasonic activated irrigation. We use 12 milliliters of irrigation in total. Um, and during the 3 cycles, we replenish the solution 3 times. Then we inactivated the sodium hypochlorite with sodium thiosulfate, and we took our sample, our S2. Then we use the OmniClean, which probably you have seen it the last couple of years at the AE. They have been at the AE. It's they call it a dynamic cavitation. It's a device that injects water at very high pressure inside the root canal and helps you debride the root canal and disinfect. So we did also 3 cycles of 30 seconds with the same, basically the same protocol as ultrasonic irrigation. Then group 3, we used the Edge Pro. We flooded the pulp chamber and we used a number 2 laser tip, and we activated it for 30 seconds in a static position, then resting 30 seconds, and then continuous replenishment of the solution until we got 12 ml total. And the settings, well, you know that the people who uses the Edge Pro, you know that each step has different parameters, so we move the parameters accordingly. And on the group 4, we use GentleWave 0.5% and 3%. But because in the other groups we use 0.5%, we stick with the 0.5%. And we added a fifth group with a 3% of GentleWave. So this is the device. The device has this plastic tube with a solution and a powder, and this swab. So whatever is inside the root canal, after we clean and shape, we disinfect and we did the ultrasonication and all that. We inactivated the sodium hypochlorite with sodium thiosulfate. Then we irrigated with water, and we suck out that water. Then we wet with that water. We wet this swab. We introduce it into the test tube, and we break the membrane that has here that mixes the powder and the water and pick up whatever is here. And then you take it into the endocator. You turn it on. And in just 10 seconds, it's going to give you a reading in between 100, 0, and 100. In this case, it gave us a 6 on its reading, probably this one or this one. But so these are the bacteriological results, the serial dilutions that we did with ultrasonic irrigation. We did it 3 times in order to check that the results after each cycle. Here's our S1, the amount of contamination of the root canal. The S2, this is after the treatment we did. And this is the endoactivator, the first reading, to check the reading of this amount of bacteria. As you can see here, it gave us 100 plus, 100 plus, 100, 77, 97, 90, 84, 61. And then after the first cycle, the second cycle, and the third cycle. With the GentleWave, we only did it once. With 0.5%, we got once in the first reading. With the 3%, we got higher numbers. It could be related to the anatomy of the tooth, whatever. So on the statistical analysis, there were differences in between S1 and S2, obviously. So each one of the techniques we use work. And there was a statistical analysis in between GentleWave, 5.5%, 3% on the clean, and ultrasonic towards the Edge Pro. Was there a difference in between the other techniques? No, there was not. They were very similar. So why we are here today? We are here today to learn to discuss if what we're doing so far in our clinic is working for us, or we want to make a change to one of these techniques, right? So you want to get something like this, or you still want to keep doing something like this. This is a fin full of debris, some debris among the sealer and the gutta-percha cone, or a complete good clean root canal with a solid obturation. By the way, this is H plus, it's not, and this is BC sealer, single cone technique. So this is what we normally do. This is what we normally find. A big discussion that I have had lately is people talk about what they believe, what they think, what they're doing in their offices. This is what we are doing, but based on what I find in the lab, doing histology, doing cross section, doing SEM, etc. I'm showing you. That's why the title of the lecture tonight is Tissue Talks, because this is what really happening. So this is a distal root canal that was instrumented to the 2004, and look at the amount of pulp tissue left behind, okay? After doing irrigation, ultrasonic or needle irrigation. This is a 2004, right? The voice really doesn't bother me much. This is BC sealer, but look inside the isthmus. This is debris. This is debris that we're not gonna be able to remove it. It doesn't matter that we use ultrasonic or we use laser or we use Odne clean, the hydrodynamic cavitation. This is another sample here, 2004. Look at the amount of debris located here, a little bit of sealer in this area. This is another sample. Here in this fin, we can see how the debris was pushed into this area here, the sealer here. Again, I don't bother much about the void, but looking within the isthmus. All this is debris, pulp tissue, etc. This one is the root canal, not too much debris, but here it is. This is a root canal done by one of the predoctoral students, right? Distal root canal of a lower molar, instrumented to the 3504 with rotary instruments and obturated with a single cone technique, supposedly, single cone technique with BC sealer. BC sealer has no problem flowing. See how nice it flows around everything? Even in between here, the debris and the canal wall, it flows beautifully. But this is what is being left behind when we do conventional irrigation. Or we want to have cleaner isthmuses where the sealer can flow and fill up those spaces. Look at this one, 2004. Look at large isthmus. Look at the fins here, obturated with sealer, the BC sealer in this case. Look at this one. No debris, the sealer flowing with no problem. So I believe that we would like to improve what we're doing, right? Lately, people are talking about the prognosis of the root canals. It's very hard to prove the improvement. And I was mentioning that, and probably we're going to talk about it later, that, for example, ultrasonic hasn't been able to prove an increase in prognosis. So it's very hard to do it, but it is what it is. So the histological analysis is what I learned from Dr. Langeland, who says in pulp biology, as in endodontology, opinions may differ, but only cells distinguish between fact and fiction. That's why I'm telling you, tissue talks. So the histological analysis is we can assess the debris removal, how efficient it is by doing these histological sections, the distribution of the debris, where that debris goes, the reduction of bacteria. Obviously, we have different staining techniques for the tissue detection or for the bacteria detection, right? With histological analysis is very difficult to quantify the amount of bacteria, but we can see the presence of bacteria. So the common irrigation techniques that and histological outcomes is the sonication often shows improved debris removal compared to traditional methods with reduced bacterial count and less inflammation. There's plenty of papers in the literature where sonication is equivalent to ultrasonication or needle irrigation. Ultrasonic irrigation, similar to sonication. Back in the 80s, Walker and Del Rio and Langeland and Pascon, they published a couple of histological papers where they compare the sonic and ultrasonic instrumentation of the root canal. So the idea behind this was to know if the sonication or ultrasonication were able to do a better removal of the pulp tissue from the root canal. But what they found was a lot of root canal transportation and a lot of pulp tissue remnants inside the root canal after the instrumentation. So basically, these techniques didn't survive the 80s. I have never seen anybody else doing sonication or ultrasonication instrumentation of the root canal. Those papers are found in the Journal of Endodontics back in 85, 88, 89. Laser irrigation, it can exhibit excellent debris removal and bacterial reduction, but careful evaluation is necessary to assess potential thermal damage to the canal walls, especially we using the erbium chromium YSGG laser. Hydrodynamic irrigation, this is the new device, the OdneClean. And the multisonication or GentleWave, it demonstrates superior effective debris removal and bacterial reduction. And I put tips in parentheses. Why I did that? Because after all these years, I have been doing this research for over 20 years. And I have done a tons of tests with all these different techniques. And the phenomenon that PIPs creates inside the root canal by producing these macro bubbles and micro bubbles that they are formed, and within microseconds it is form and explode, is form and explode, is form and explode. Well, this streaming that is being produced is so vigorous that goes deeper into those difficult to reach areas and helps to remove bacteria better. Especially the microbubbles are responsible to go into the dentinal tubules and swipe everything out. So with the histological evidence that I have, I can prove that PIPS does a very good work removing bacteria from inside the dentinal tubules. But it doesn't do a good job in pulp tissue debridement. Okay. But for what I'm going to show you, the pulp tissue debridement produced by GentleWave is way much better than any other technique. It does a very good job in disinfection, but not as good job as PIP does. Why I don't mention sweeps? Because I haven't done any tests with sweeps. I only have done tests with PIPs, so I cannot talk on that aspect with sweeps. I can talk different aspects of sweeps, but not in the disinfection aspect. Sonication, we have a publication, Dr. Ordinol and myself from 2016, where we proved that sonication and positive pressure is basically the same. And I'm going to show you a video proving why it doesn't work. So the hydrodynamic cavitation is a phenomenon that occurs when a liquid is subject to extremely low pressure condition. This low pressure causes the liquid to vaporize, forming small bubbles. When these bubbles collapse, they generate intense localized pressure and temperatures, creating shock waves. So this is basically how the laser works, right? So it is a matter of producing these gas bubbles. So challenges and consideration. It's very interesting that standardization. We need to standardize what we do. we need to standardize the type of anatomy we're working on. We need to standardize the size of the root canal. We need to standardize the amount of solution we are using. So in order to get accurate comparison in the results. So the sample size also, that's challenging because in order to get a good statistical comparison, we need a lot of samples. So we are going to use the histological analysis to find what we can really see. There's one of my very good friends, Dr. Gary Carr. He has done what he calls biopsies of extracted teeth treated with different techniques under the SEM. Those are good evidence. The SEM is a good evidence because you can see in higher magnification what's left, what is left behind or what is not left behind, and you might find the cause of the failure. But the problem with SEM is that you can only see the surface of the sample that you cut. With histological, we section the whole tooth, so we can stain every single slide, so we don't lose any detail at all. So probably with SEM, you can catch something very clean at the surface, but probably deeper inside, there's the reason why it failed, or the other way around. Probably we find a lot of debris in some part, and the rest is very clean. So SEM is a good alternative, but not as good as histological evidence. So I'm not going to repeat this. We have gone through all this. So the bacterial reduction is very important. Here, this is a picture in one of the textbooks that was written in Portuguese. Dr. Carlos Bueno's excellence in endodontics, in clinical endodontics, and we can see very little amount of bacteria left behind in one of these contaminated teeth with E. faecalis. So this is how the phenomenon of the multisonication or the streaming acoustic produced by laser, how they go and penetrates into the dentinal tubule. So they both do a good job. As you can see here, this is a fused mesial and palatal root. You can see a big penetration of the sodium hypochlorite. This dentin was colored and then it was bleached. And this is with lasers. So they both do a good job. So I wanted to test the efficacy of these different techniques. So this is we use fresh extracted molars with diagnosis of SIP-SAP, symptomatic irreversible pulpitis with symptomatic apical periodontitis. And these are the controls where we can see the presence of inflamed pulp tissue, a lot of hemorrhage inside, and some inflammatory tissues, cells there. So the power of sodium hypochlorite compared to the still water. This is saline. Look at the great amount of pulp tissue when we use saline as an irrigant. The root canal, the root canal normally is clean. The root canal, we have no problem cleaning the root canal. But where we found those fins, where we find those isthmuses, is where it is that 35-40% of the root canal that wasn't touched. Okay, so sometimes there is these calcophyrates areas where the instrument doesn't touch and bacteria hides in those microscopic spaces. So this is saline. This is saline. Look at this fin here, this isthmus, the entrance of isthmus, this other isthmus. The root canal, some pulp tissue here left behind, as we can see, when we use saline. So this is positive pressure, sodium hypochlorite 6%, 2 milliliters after each file, enlarged at 3504. Again, the root canal, there's no problem, but the more apical we go, there's a pulp tissue. Look at this distal canal, a lot of pulp tissue. And in the apical portion, a lot of pulp tissue. We didn't have any isthmus in this root. This is the distal root. This is another case. Is the pulp tissue located in the isthmus area and the fins, in the coronal portion, the mid portion, and in the apical portion with multiple foramens. We see the presence of pulp tissue there. This is the distal root canal. Some pulp remnants still left behind within the root canal. This is ultrasonic irrigation. Again, no problem cleaning the root canal. Look at the isthmus with the tissue here in the multiple foramens. Here we see still some pulp tissue. This is the distal canal, coronal portion, middle portion, apical portion. In that multiple foramens, we have the presence of pulp tissue. Hard to clean. This is another case of ultrasonic irrigation. Still a bunch of some areas of pulp tissue remnants here in this lateral canal here, obviously. Here the distal root, the main foramen, and two accessory foramen here. This is not pulp tissue. That's an artifact. Okay, Odne Clean. When I started using the Odne Clean in the lab, the technique is to use only water. And I found a lot of pulp tissue after the use of Odne Clean. So I recommend Odne Clean people to improve their protocol. So they say, okay, let's instrument to the 2004, and we're gonna use 4 to 5 milliliters of sodium hypochlorite in between files total. And let's see the 3 cycles with EDTA of the clean. And we found less amount of the tissue with we use sodium hypochlorite, but still there was some in those difficult to reach areas. But the rest is pretty clean. This device cleans very similar if we do positive pressure or we do ultrasonic irrigation. There are really no difference in between. So this is the Erbium Chromium YGG laser. This is the H Pro. Again, instrumentation to the 2004. This is the mesial root. Here we didn't the pulp tissue wasn't derived from this area. The same with in the most apical portion. There is still pulp tissue there. This root canal was clean. This probably the main canal split it in two, and the effect of the laser didn't reach this area, as we can see here. And this is what I was telling you about the H Pro tips. You need to be, if you are a user of this laser, you need to be careful. You need to replace the tip in every case. This is the halo that is being seen when we have a brand new tip, and this is the halo is lost after the use of the tip. This is the power meter device that we use. So we measure the amount of power that is being delivered before use and after use. And because of the degradation of the tip, the amount of the power is totally reduced. So probably it's not that this type of laser is not as good as the erbium jack laser for endodontics. But the problem probably, and this is something they need to look into, is that probably the problem is the tip. Probably their tip is not allowing the laser to be properly absorbing the solution. Okay. It's not the technology. Probably it could be the tip. I don't know. And I'm not going to investigate that because I'm distracted with other projects. So Fotona came up with a new tip. It's called sweeps. It's in design similar to pips, but because of patent issues, they couldn't use the same parameters, so they went around and they have this auto sweep mode that really put the tip in the pips mode. So it's a mess. But anyhow, sweeps is like Dr. DeVito says, is pips with steroids. It's more aggressive because every 25 microseconds compared to 50 microseconds impulse. So because it has double the impulse per microsecond, that's why we see uh, more cavitation, more streaming being produced. So these are the results. The debridement is not that good, as we can see here. I'm gonna rush because I'm running out of time. Something I noticed with the use of sweeps is that the needle I was using to irrigate got constantly blocked. So I saved those needles and I found this deposition of crystallizations, probably because it's so strong, the absorption of the sweeps into the solution, that probably it evaporates the solution and it makes the elements get trapped into the needle. So probably that's the reason why. So I took it to the SEM. I did an element analysis. This is the stereomicroscope picture of the areas that I analyzed. This is the SEM picture, how that crystallization is located, and obviously we found rest of sodium and chlorine in this crystallization. So that backs up what I think is happening. Uh, I think that you cannot see, but it says speeds here is 20 millijoules, 15 hertz, 50 microseconds, 3 watts. So we did pretty much the technique. This is the mesial root. We found some fault tissue in the isthmus area, which doesn't surprise me. In this thin area also, which doesn't surprise me. This other canal is very clean. But again, where that root canal meets its challenging as anatomical aspect, the anatomical challenge, which is a fin or the isthmus, the presence of the isthmus or lateral canals, is where it gets complicated. So the mesial, the most apical portion. This is another one, very clean. And this is compared to some studies that done by Dr. Ricucci and Cicada, where they did this study in necrotic cases. They did the micro CT before and after, and then Dr. Ricucci did the histology, and where they found in the micro CT the presence of still tissue left behind, it was correlated with the histological sectioning of the tooth, and this is Brown and Brand for the bacterial detection. All this purple color is bacteria. So they localized a lot of debris left behind after the instrumentation and irrigation of the root canal. But, excuse me, I'm sorry. But Dr. Siqueira, uh, he had the philosophy or of enlarging the root canal a little bit more. As you can see, this root canal preparation, these are big sizes, but at the same time, it doesn't matter that you use, again, the blue or the gold or the pink alloy, you're still gonna have root canal transportation. It doesn't matter. And it makes no sense to enlarge more because you're enlarging in this direction, not in this direction, right? So that's their philosophy, as we can see here also. See, the transportation is being this way, not into the isthmus. So basically, you are doing nothing. So my mentor, Dr. Arreola, and myself, we published this GentleWave paper where we also compare the efficacy of GentleWave. Uh, this is the coronal portion of the mesial root canal. The isthmus is very clean. As I show you those stereomicroscope pictures, uh, with the sealer flowing with no problem in the isthmus, is because there's no debris. Nothing stops the sealer to flow into those areas, right? As we can see here, the middle portion. Here, in this fin, there's definitely there's bacteria, pulp tissue located there. It wasn't removed with the GentleWave. This is the same section, but I put it like this because there is a lateral canal here, all right, in this mesial root canal, and this lateral canal is completely clean. Here is another sample. Tissue in the isthmus, of course, is not 100%. Um, uh, it doesn't have 100% efficacy, but it's very, very clean compared to other techniques. For example, this one, I wasn't able to localize this root canal from the mid portion. This is the coronal portion from the mid portion. I'm sorry for this picture. This is wrong here. But look at this. This wasn't instrumented, and look at the isthmus. It's completely clean. There is a lateral canal here, and this is the most apical portion. You know, the gentle weight technique dictates that you need to stay, I don't know, they change constantly, but I like to stay 1.5 millimeters short from working length, my instrumentation. So this picture is from 1 millimeter from the root tip. So this area wasn't instrumented, and it was completely clean. The C-shaped canals or C-shaped molars, normally the second lower molar, right? But this is what we find in the clinic. And normally when we see this C shape, normally we find still pulp tissue in these isthmuses. We can see the instrumentation of 3 root canals here, but in this case it's completely clean. This is the coronal portion, and this is the apical portion. It's completely clean out of any pulp tissue. So with Alex Plagenhoff, one of the pre-doctoral students, he presented this poster at the school and then at the Star of the South, where he won second place. And then he presented it at the 2018 AE meeting, where we compare the conventional instrumentation using ultrasonic irrigation versus gentle wave. We wanted to check the amount of debris left behind and the voids created. And these are the results. With conventional instrumentation and ultrasonic irrigation, we found a lot of debris in those difficult to reach areas, in those isthmuses, some voids that probably were created because of the presence of this debris, versus the samples done with GentleWave, where we didn't find any debris, and the sealer was able to flow with no problem. Here we have more samples. These are GentleWave. And some cases that has been treated with GentleWave but have failed. Well, the reason for this one, the reason why it failed is because the tooth was cracked since the beginning. So the dentist talked to the patient, and he said, well, we have this new technology. We're gonna give it a try and see if we can save the tooth. But unfortunately, the patient came back to the office 3 months later with severe pain. So the tooth was extracted. The tooth was sent to me. Here I resected the tooth to do the histological section. And in the coronal portion where there is more contamination, we can see a lot of bacteria and necrotic pulp tissue related, not necrotic pulp tissue, I'm sorry, this is contamination inside the crack. So this is the crack, but inside the root canal is very clean. This black material that you see here is the sealer. Here we go to the mid portion, bacteria with indentinal tubules, but no remnants of pulp tissue left behind, only sealer in this isthmus area. The orange sections are ground staining for bacterial detection. This is H&E for pulp tissue detection. Basically just the sealer. The sealer moved from its original position inside the root canal. So the root canal is very clean, but the reason for the failure was the crack. Here is another case of a cracked tooth. The reason why it failed was because of the crack, but the dentist, the endodontist, asked the patient if she wanted to give it a try. They didn't charge for the root canal. He did the GentleWave treatment on this tooth. It was vital. You see the crack here. And we can see with the transillumination the presence of the crack, and the root canals are clean. And this is the most apical portion in the distal root canal. So the foramen is located laterally, as we can see here. So here is the sealer, and all this is the pulp thumb. The tissue is a little bit inflamed. There's a lot of inflammatory cells here. And so it respects the multisonication. A lot of people ask me about the possible extrusion. It doesn't go beyond this point. Here is another C shape that was treated, and unfortunately it didn't work out. Why? Because it was cracked. But as you can see here, the root canal, the C shape is very clean. Only the presence of the sealer, no remnants of pulp tissue. And we see some bacteria in the coronal portion, inside the dentinal tubules, some in the mid portion, and in the apical portion. This is the sealer in the most apical portion of the root canal, and this is the crack, and obviously uh, totally contaminated. This is another case that was treated with GentleWave. In this case, we can see some remnants of bleeding here. Some users claim that there's post-treatment, post-GentleWave, or post-PIPS, or post-sweeps bleeding. So there is pulp tissue in the isthmus, definitely, but mostly bleeding. And probably this is what happened in this case. Some blood cells here, some pulp tissue here in the isthmus. So basically, this is what we found in this case. So why multisonication doesn't work? I mean, sonication doesn't work. I'm sorry. This is a video done by Dr. Hebranson. You will see how the sonication tip comes in vibrating. And this is exactly what happened with sonication, exactly the same phenomenon. So as soon as the tip have a contact with two surfaces, basically the effect is shut down. We're gonna see here. See how the tip is vibrating, and as soon as it has a contact here and here, it stops the vibration. We don't see anything happening here. And this is exactly what happened with ultrasonic. A lot of people tell me, David, there's a bunch of studies from ACTA back in the 90s, in the 2000s, where they demonstrated that ultrasonic irrigation is very, very effective. Yes, in virtual studies, of course, because in the virtual study, the ultrasonic probe is vibrating freely. It's not facing this. So we connect the GentleWave, and as soon as we connect the GentleWave, we can see the activity in these lateral canals, right? The bubbles that are inside the root canal are going to be little by little dislodged by the degas solution, but we can see how fast this works, especially in these lateral canals. So with one of the preceptors, we wanted to try to see if the multisonication effects, multisonication have any effect beyond a broken instrument. So we work and we use H Pro, ultrasonic, and GentleWave So we used three different type of scenarios. One was a MB1 and MB2, and we fractured the file before they joined together. The type 2, we fracture the file, blocking the MB2, and the third one was only one root canal. So these two, if you are in this situation, whatever is left behind here is going to stay there. So no laser, no multisonication, no ultrasonic is going to be able to reach the pulp tissue located in this area. So the interesting part is to see what the technique can do to the tissue remaining in this portion, and without instrumenting, what is the condition of this other canal. So this is what we found. We found pulp tissue beyond the broken instrument when it was blocked. So there's no way we can find it. So this one is GentleWave case one. As we can see, this is the coronal portion, the mid portion, and the apical portion of the root. There's no pulp tissue. The multisonication was able to remove the pulp tissue. There's some remnants here, very little remnants. This is the uninstrumented distal buccal root canal, I'm sorry, clean, and the palatal canal. We didn't instrument those canals, okay? We just hooked the clean flow to the tooth, and it did its work without instrumenting these canals. With H Pro, the coronal, this is the coronal portion, MB2, pulp tissue there beyond the broken instrument and in the apical portion. So the effect of the laser didn't reach that area. The distal canal that wasn't instrumented, well, we found some effect of the laser, but some remnants of pulp tissue. And in the palatal root, the pulp tissue was not debrided, the coronal portion, the mid portion, and the apical portion. Ultrasonic, it left a lot of pulp tissue. This is the palatal root. Obviously, it didn't clean anything because we didn't do those canals. So the positive pressure is going to leave some of it's going to help a lot, but it's going to be the less effective technique in irrigation, but the most used one. Ultrasonic, while is more effective than positive pressure, but needs to be instrumented at least to the 3504, so you can vibrate inside. On the clean and erbium chromium YSGG laser, they will leave pulp tissue behind. The erbium jack laser will also leave pulp tissue behind. And then GentleWave was the technology that left the most clean root canals free of any pulp tissue debridement. So basically, this is the way how GentleWave works, how PICS works, and what is the effect of tissue dissolution in between these two. So we can see that this one is getting reduced in size, the same as this one. But at the end of the video, this one is going to be totally removed. Here the multisonication is working all the way down. So this is basically the way they work. So in summary, the histological analysis of extracted mandibular molars revealed that achieved complete removal of pulp tissue from the complex root canal remains a challenge, as previously reported in the literature back in 1922. Despite the advancements in instrumentation technique, residual pulp tissue was consistently found in areas such as isthmuses and lateral canals. Sodium hypochlorite was confirmed as an essential solution to be used while we mechanically instrument the root canal for the disinfection properties and the dissolving tissue properties. So these findings, histological findings, confirm that we still have a work to do, and we're working on it. It's very hard to get there. There are more things to come. We always trying to improve. Well, the science, the field of endodontics, there's always something new. I'm gonna start testing new lasers. Seems that there are some improvements in multisonication, so we're gonna try to do that. So the use of smaller files, I believe that we should extend the lasers and multisonication works the phenomenon, the streaming acoustic or the cavitation cloud and this hydrodynamic cavitation being created by GentleWave, they work better in smaller areas. That's fine. You can do a small instrumentation and then run your technology and then keep incrementing because I strongly believe, especially in vital cases, that we need to help us debride the pulp tissue with files or with barber brooches. It is possible that in certain specific situations, the use of barber brooches are still indicated. So this is my email address. I'm sorry that I went a little bit over the limit. They asked me to stop at 110 or 115. It's 125. I'm sorry that I went over the limit with the time. This is my email address. Please feel free to email me anytime. And I don't know, Wendy, we still have time for questions, or they can submit the questions and I can reply to each one of you by email address.
I
Thank you
think
so
that,
much.
thank you so much, David. That was just an incredible amount of information, and your dedication to the specialty is incredible. So thank you for all that you do. We did get one good question. It was from Greg, and he asked, does canal preparation size affect the hydrodynamics of gentle wave?
Yes, as I was explaining at the end, what we have seen is that the phenomenon works better in smaller areas. So, for example, when I train the residents to use the Edge Pro or to use the GentleWave, and I play a little bit with them, I'm a little a little bit devil with them. Is that okay? You just need to instrument to the 2004, and then they come frustrated. Dr. Jaramillo, I cannot feed the Garaperche cone. That's
Sure.
fine. You can increase the size, no problem. But first, make the technique work as is indicated. Then later on, if you want to increase the size, that's fine.
Great. Have you had any time to look at any closed system negative pressure irrigation?
Well, yes, I have done a lot of the endovac and this total vac now. Um, yeah, they work as long as you use a good amount of solution. Yeah.
Okay. Have you had chance to look at the pulp sucker?
I did some studies for Steve 2, 3 years ago where we did micro CT, and he uses an enhanced sodium hypochlorite. Um, and The use of enhancers in sodium hypochlorite obviously increases the dissolution of the tissue. So what I did for him was to test the pulp sucker with his solution and then with sodium hypochlorite. And we did micro CT, we did the before and after to see the amount of pulp tissue left behind. And there was no big difference in between the enhancer and the sodium hypochlorite. But there was a difference with ultrasonic. So we compare it to ultrasonic, and when we use pulp sucker with enhancer and ultrasonic with enhancer, the ultrasonic did a better job with ultrasonic and sodium hypochlorite. I don't know if I make myself clear. So the enhancers make a job, make it works in debridement of the pulp tissue or dissolution of the pulp tissue. I mean, so yeah, the pulp sucker it works, it's good, but I don't know. You need time to set it up.
Sure, sure. Thank you for answering that. I think it's a good idea since it's getting late. I'm going to give you one more, and then we're going to go to a review on what's next with our study club webinars. Manish asked, do you have planning any studies to evaluate whether we can shorten solution times using 3% hypochlorite in the GentleWave for tissue dissolution and disinfection, but still maintain efficacy? That
Using less time or less solution.
shorten solution times. So
Okay.
yes.
Shorten solution time. N- Not not necessarily the way Manish is asking, because where I'm going now is the other way around. I'm going into more concentration of sodium hypochlorite and
Mhm.
probably more time.
Sure.
But at the same time, it can be, I don't know. Yeah, that's a good
Yeah.
idea. We can do the less timing and see if there is a difference.
So with our new Pro controls and the G4, we're offering such flexibility to increase time, to increase 5% hypo. So as we evolve, we will be able to look at time and percentage of solutions and see what's the perfect concoction there.
Okay.
I am going to finish us up a little bit and go into what is next with our webinars here. So please join us for our next study club, GentleWave. It's always on the third Wednesday of every month. Our next one is June 18th, and it was going to be with Dr. Mustafa Gundagar. He's coming in from Turkey. It's going to be a live webinar. He has also done some research looking at all the different irrigation techniques. So this should be a very special webinar with some live Q&A, and please mark your calendars. We also please visit gentlewave.com to learn more about our upcoming hands-on courses. This course is in June 28th. It's in Nashville. It's for brand new users and experienced users. It's always a full course, and Dr. Davis and Dr. Yules have an incredible facility right in the heart of Nashville to have a good time in too. So thank you everybody for your patience. We went a little late, but it was a lot of information that I certainly didn't want to rush you. Everyone go enjoy your evening. Turn in your surveys. We'll send you your CEs and we will see you soon. And thanks again, Dr. Jaramillo. Appreciate it.
My pleasure. Thank you so
Okay.
much.